Hello and welcome to Cancer World. I am Sergey Badalyan, and today I'm joined by Professor Johan van Meerbeeck, a pioneer in thoracic oncology whose work spans clinical care, translational research, and health policy. Professor Meerbeeck, thank you for speaking with me. To set the stage, let's start with your path into thoracic oncology and how your perspective has evolved over the years.
So good. Hello. So I'm indeed Jan van Meerbeeck. I started actually as a medical specialist in internal medicine. Then I turned to respiratory medicine or pulmonology, and having practiced for about 40 years, mostly in treating patients with thoracic cancer, some lung cancer, mesothelioma, and thymoma. I can call myself a thoracic oncologist. So that's a medical specialist specialized in treating patients with thoracic cancer. So my background still is respiratory medicine. So I did that in several locations. So I started my career in Antwerp, in Belgium. That's where I also graduated and obtained my PhD. And then I went to Rotterdam, the Erasmus MC Hospital in the Netherlands, which at that moment just had become a joint venture of two smaller hospitals. Before moving to the Ghent University Hospital back again in Belgium, where I was also professor at the university, before returning back to Antwerp for becoming the head of the Department of Thoracic Oncology and also the Department of Respiratory Medicine at the end of the career. So I retired now about 4 years ago, but I'm still I'm still busy with doing clinical and translational research with my PhD fellows and with my colleagues. So that's about stage.
Dr. Meerbeeck, can you remember what first inspired you to specialize in lung cancer specifically? And how has your perspective evolved since your early years in Antwerp?
So why did I choose lung cancer? That's when I was a trainee in the Department of Respiratory Medicine, there was no one else involved or interested in lung cancer. So the lung cancer cases increased. We had several cases a week, but there was no one specifically interested in the care or the management of lung cancer. Certainly not in the systemic therapies or the treatment with chemotherapy. We had only 2 or 3 drugs, but definitely all things started with the treatment of small cell lung cancer, in which spectacular responses were seen, although not lasting long. But it all changed over the last 40 years. So it first came with the CT scan. Can you imagine staging a patient without a CT scan? Then we had the PET-CT, then the chemotherapy, the evidence that platinum-based chemotherapy was also effective in lung cancer, and then early 2000 we had the start of the targeted agents with the gefitinib and the erlotinib trials, and then it all ends now, for the moment, with the immunotherapy. Which is definitely has a groundbreaking effect also in lung cancer patients. Besides that, I've seen a revolution in radiation techniques, also in operative techniques. So we now operate the keyhole. We do the routine keyhole surgery or even robotic surgery instead of the large incisions with the pneumonectomy, which was more or less the standard 40 years ago. So it has all changed a lot, and I'm very happy and proud also to be part of this revolution in the lung cancer care over the last 40 years.
Dr. Meerbeeck, I also know that your 1997 PhD examined lung cancer presentation in formularies. Looking back, how has the epidemiology and public awareness of lung cancer in Europe changed since then?
Well, as you know, the lung cancer epidemiology follows the smoking habit with about an interval of 20-25 years. So definitely we see now, since a couple of years, a first slow decrease in the incidence of lung cancer in males. But unfortunately, women have picked up the bad habits, and so lung cancer incidence, at least in Western Europe and in Belgium, is now still increasing in females. So on average, so altogether, the annual incidence has still increased as a total, and this is definitely not to be proud of. And it all reflects the smoking habit. Public is aware of it, and definitely also the anti-tobacco campaigns of the government have made it more, have created a better awareness. But when I see in the streets young people still smoking or using other drugs like marijuana, coke, etc., I'm afraid that they haven't learned the hard lesson yet.
Of course, it is said that still the numbers are increasing, especially in the female population. But hopefully, the statistics will change soon, especially after the projects that you are trying to implement. And also, you've been a pioneer in breathomics, studying exhaled breath to detect cancer. What drew you to this research, and how close are we to seeing breath-based diagnostics in clinical use?
I'll start with the first question. So, breath is among the easiest accessible biofluids. So you have 15 times a minute, you exhale breath, and it contains volatile organic compounds, which can easily be sampled and analyzed. So it's quite obvious. There is a little bit of serendipity also involved. Why did I go into breath? Obviously, there were a number of reports. I don't know whether you still recall it, but there were a number of reports on rats that were used in demining minefields I think it was in Africa, and then the dogs that were used to screen for explosives in the airports, etc. So it was something that was close to things that already were used outside of oncology, outside of medicine. So what's the status for the moment? So how close are we going to use it? I think it's not yet that close. The big problem is that we need validation studies. So a biomarker needs several steps before it is being used. And we have several validations studies and validated biomarkers, but the clinical utility has to be proven. And that takes a randomized trial against standard approach. And for that randomized trial, you need thousands of participants, money and time. So I think that breath will make it, but it will still take at least 5 years before it will be available for the early detection of lung cancer.
Thank you so much for such insights. I would love to speak a bit about mesothelioma, as I know it has been one of your lifelong research interests too. So what advances give you the most optimism today about the mesothelioma? And what challenges remain for patients exposed to asbestos decades ago?
Yeah, this also goes back to my first years in residency, when the first cases of mesothelioma in Antwerp were diagnosed in our hospital. And we saw week after week, we saw the number increasing. So that was the reason why I got interested in studying mesothelioma. So I've done this now for about 40 years, and I think that the first step was the chemotherapy, which was at the end of the 90s of last century. But nowadays we have like in other cancers, the immunotherapy as being the most important step in the last 10 years. But still, it's not like in other cancers, like in melanoma and in lung cancer. So the improvement is slow. It will take time. And one of the reasons, obviously, it's because it's a rare tumor. So you can do large randomized trials, or you can easily do those randomized trials. But there's the fact that there is a limited role of targeted agents, so that the burden, the tumor burden and the effect of the role of oncogenes is limited. It's mostly suppressor genes that play a role. So I don't think that targeted agents will make it in the treatment of mesothelioma. What is a new finding are the cases of so-called familial BAP1 syndrome, in which the majority of the products will develop a mesothelioma. And in those cases, definitely early detection can play a role. And this is currently being studied in a couple of centers, whether or not those problems with BAP1 syndrome should have a prophylactic correctomy. And here too, what can we offer asbestos-exposed individuals? Screening is still not, screening for mesothelioma is still not accepted because we don't have a treatment, a curative treatment. We are currently also doing breathomic tests in order to look for a signature of asbestos versus the signature of mesothelioma. And we have some promising results there. We have a cohort of asbestos-exposed individuals in which we see a possible signal which differs from the one from asbestos. But once again, this will need further validation and a clinical utility testing. So for the moment, I can only say avoid asbestos when you're young.
Dr. Meerbeeck, you have led clinical and translational studies across disciplines for years. I would like to know what you see as the key to effective collaboration between pulmonologists, oncologists, and molecular scientists.
Communication, equal partnership. Consider your collaborators as your equal partners with another interest, with another specialty, and mutual trust. So trust them when they come to you. Trust them that they are keen, that they are sincere, and that their observations are well done. So I think these are the three keywords: communication, equal partnership, and trust. Mutual trust.
Amazing. So communication, equal partnership, and trust. Are these like golden advice by Dr. Meerbeeck for an effective collaboration? And besides like this collaborative work, you have led positions in EORTC and the European Respiratory Society. What lessons have you learned about steering large international cancer research networks, besides running an effective communication, of course?
Well, okay, the European situation is special in that sense that obviously you have people from different specialties. So in the EORTC, we have radiation oncologists, have medical oncology, have surgeons, with pulmonologists. So the difficulty there was to find common goals, which could in which everybody could have his participation and his credit. So there, that's also the strength of the ERTC, is that doing trials in multimodality treatment definitely has been the main impact of the ERTC. And I regret that nowadays I'm too much interested in doing drug only trials and not combining the multimodality treatment. And then regarding the European Respiratory Society, which is obviously more the society of respiratory clinicians, we had to understand that as respiratory physicians, our strength was in screening, early detection, diagnosis, and staging. These are the things that the average pulmonologist should know and should be good in. We will never, so the average pulmonologist will never beat the medical oncologist or the oncologist with the use and the treatment with drugs. And the medical oncologist uses it every day in all kinds of situations. So he will be much more aware and have more expertise than the average pulmonologist. But the diagnosis, staging, and treating and screening. These are the issues in which we as pulmonologists can contribute a large part in the management of the disease and collaborate on an equal partnership with the oncologist. This is not to say that in certain countries, like in my country, thoracic oncologists are equal partners and also use the drugs and the immunotherapy, etc. But this is country dependent.
Thank you so much. Since you have mentioned the screening strategies, I would like to talk about this part of the topic. So Europe is now implementing the EU beating cancer plan. From your perspective, what's still missing to make early detection and screening for lung cancer truly equitable across countries?
Yeah, the awareness among the authorities and the politicians, awareness. And certainly in these budget crunch times, politicians would be more eager to spend money on tanks and on drones and on weapons than on prevention. Prevention is not popular. You don't get votes with prevention because it takes 20, 30 years before the efforts are seen. So awareness among the authorities. And the second issue that is lacking is, contrary to, for instance, the United States, we need common SOPs and GCP guidelines to do the lung cancer screening. And here too, the field is very disparate. And just setting even the thresholds for screening, the age threshold and the smoking thresholds is very difficult across Europe. In some countries, they have more or less blindly adopted the criteria, the categorical criteria of smoking intensity, smoking habits. But you have to realize that you miss half of the incident annual cases if you just look at smoking habit. So there must be a way of fine-tuning the inclusion criteria for the screening. And this is one of the reasons for the politicians and the authorities to hide behind and say, okay, as long as you don't have a more validated and structured way of identifying the risk, it will not succeed. You cannot ask millions of adults who have smoked or smoke to be screened with a CT scan, which more or less costs about 150 euro per scan, besides the radiation risk, just to pick up 2 or 3 lung cancers in an early stage. So, although the evidence of cost effectiveness is there, the implementation at the local scale is lagging behind. And okay, this is the task for me and for other clinicians to pick up that and to sensibilize the population and to address the issue in the media to the general public and the politicians.
Dr. Meerbeeck, since you mentioned that the lack of awareness is the number one problem for such implementations in Europe, in your view, what are the practical steps that European health system should take now to implement those equitable, high-quality, low-dose CT screening so that benefits real-world populations rather than just trial settings?
So I think the first step is to do local implementation studies. Right? So do local small-scale local implementations, not looking at the primary endpoint of mortality and reduction of mortality, but looking at practical issues like what is the pickup rate? So how many of your people, how will you address people? Will you make it a population-based or through the GPs or through the health system or through the medical files? How will you address your at-risk population? How do you avoid to missing a certain category of smokers like what we call the fourth world or the less medically educated people who are the ones who smoke the most. So these are all issues to be addressed. We must absolutely avoid of making it cherry picking exercise in which only the wealthy and the more the well informed smokers and ex-smokers are offered the procedure. So it must be at the end a truly based population-based screening effect. So my advice would start with implementation studies by reaching out to as large as possible population of attendants.
Do you have an answer to how to avoid overdiagnosis with such implementations?
In my view, overdiagnosis is a false issue. What you should do is just avoid interpreting your data, analyzing your data too early, because overdiagnosis decreases with the time you wait after the last screen. So the earlier you analyze your data, the higher your overdiagnosis will be. So, and there are now some recommendations that you have to wait for at least the same period between the first and the last screening round before you analyze your data regarding overdiagnosis. The other issue is obvious that you have to restrict on age and on comorbidity issues, as you have to avoid taking in patients with already significant comorbidity or who are, let's say, older than 64, 70, because their net benefit will be, and the cost effectiveness will be lower than in the population which is now addressed. So, but I don't think overdiagnosis should be a cause not to screen.
Mm-hmm.
Definitely not.
Yeah, I totally agree with you. And thank you so much for such detailed insights about the screening, especially the lung cancer screening and prevention implementations.
Yeah. So the overdiagnosis is typically an epidemiological issue, but you never will know whether a case that you have diagnosed is an overdiagnosed one or not, because most patients or most cases will have been treated. And so you don't know whether it's an overdiagnosis, whether the proband will die from something else than from his cancer, his or her cancer.
Dr. Meerbeeck, I would love to speak more about your scientific background as well and your health technology assessment background as well. So, as someone involved in health technology assessment, how do you balance enthusiasm for innovation with the evidence demands of clinical practice and reimbursement systems?
Well, I've always practiced the idea that if you put your patients in clinical trials in which those new drugs or techniques are tested, they will have access free of charge for these drugs or for those techniques. So doing as a part of clinical trials, either invent one, write your own protocols, or participate in international or national efforts, pending the fact that the drug or the technique will sooner or later be approved and reimbursed by a medical authority. I think you should take the opportunity to have your patients included in clinical trials.
Also, you have published extensively and mentored many younger scientists. What advice would you give to early career clinicians, let's say me, who want to combine patient care with impactful research? Because I'm a medical doctor and a first-year resident in oncology, so this advice might change something in my career too.
Well, I have a mentor who always say, first become a good doctor. Yeah? So get your experience in the field on the ground. Then the second one is choose your topic. Choose a topic which interests you, not a topic which interests your supervisor or your mentor or your head of department, but choose a topic which interests you. And then focus. Don't try to be everything, overarching everything, but focus on one or maximum two aspects of it. And then do not despair. Surround you with equal-minded colleagues national, international, and try to find an international network on which you can fall back. And keep in mind that for every patient with the condition, to find it a clinical trial or to find a research question or a clinical trial of interest, so that every patient you see, that every patient you see contributes to your clinical scientific career because he's participating in the clinical science. So have a broad spectrum, and this can be very easy diagnostic trials or intervention trials or follow-up trials, etc. Don't lose the opportunity of a patient presenting to be registered in one or several of your portfolio of clinical trials.
Thank you so much. Thank you so much, Dr. Meerbeeck. And finally, looking back, what accomplishment are you proudest of? And what still motivates you to stay active in the fight against thoracic cancers?
Well, let's start with the clinical accomplishment. I think I've educated or trained about 25 thoracic oncologists in Belgium and in the Netherlands in the past 40 years. So I think if all these people carry a little bit of what I thought were principles of thoracic oncology, this is a good thing for the care overall. So I think this is an overall experience, an overall accomplishment over 30 or 40 years. And then my personal accomplishment, at a certain moment, I told you, I moved from Belgium to the Netherlands. So getting international. Don't stay for all your career in the same hospital or in the same condition. So move and try to change focus, either your job or your job content or what you do every 10 years at the maximum. So don't stay fixed in what you do for all your career. And so dare move, dare change your career, to switch your career to other interests and broaden your keep a broad interest. And then regarding the scientific, I think the breathomics track is definitely the one which I'm on the long run the most proud of, because it is something innovative and people are continuing. So I have now a postdoc, I have a tenure-track professor who is continuing the work, and I still believe this is a way forward. It's something completely innovative 10, 15 years ago when I started with it, and it's still expanding, and you see it in the number of publications, you see it in the number of communications, etc. That this is an expanding field. So I think these are the three issues where I think I can be proud of. And what still motivates you to stay active? Well, as long as there will be lung cancer, as long as that's we have to fight it, and I'm ready to be in the trenches for that.
Dr. Meerbeeck, your accomplishments motivated me personally as a young oncologist, and thank you so much for sharing such details and insights from your background and the work that you're doing and the research that you are involved in. Before we conclude our interview, I would like us to enter the Blitz round, which are going to be speed questions about you to find out who Professor van Meerbeeck is in life general. Okay? So I'm going to ask you several questions, and please answer them as shortly as possible with one word or a sentence, however you like to. We just want to know who Professor van Meerbeeck is. So the first Blitz question is, what is the first thing you do when you get to the hospital or lab?
Well, you have to realize I've retired from the hospital now. So, but okay, let's turn the clock back 5 years. The first thing I did was to check the agenda together with the secretary to look for any possible disturbing issues and to anticipate for the week and the days to come. So that was anticipation. You can avoid a lot of trouble by anticipating also in your agenda.
Name a book, paper, or a thinker who has influenced your scientific outlook.
So I'm very grateful to two of my. I always say you're standing on the shoulders of giants. So I'm part of my training and part of my research training. I obtained through collaborating with two, in my view, thoracic oncology giants. The first one is Professor Postmus from Amsterdam in those days, and Professor Van Zandwijk, also from Amsterdam. So they were, for me, they were two mentors in the in my national and international career. And let's say a manuscript that brought me a lot of insight and also a lot of drop-off issues was a paper on the an ERTC trial I published in, I think, 2005 or 2006 on a randomized trial with chemoradiotherapy versus surgery in stage 3 non-small cell lung cancer. This was a tremendous experience which brought me on many stages, nationally and internationally. And the book which interested me the most was a book I read, I think 3 or 4 years ago, the AI, artificial intelligence in medicine. So it was just before ChatGPT, etc. started, but it was already opening the world of AI to me and its possibilities. And I think the ChatGPT has only increased that and confirmed my suspicion that AI would be a major player in medicine in general and in oncology.
I do agree. I do agree with you. If you weren't a doctor or a researcher, what would you be doing instead?
Well, when I was young, I dreamed to become an astronaut. Okay, and then more realistically, a pilot.
Oh my God, same, honestly. Like, I always think about this question and I'm like, if I wasn't a doctor, I would really love to be a pilot.
Oh, okay. But a civil pilot, not an army pilot, a civil pilot.
Yeah, yes. So what's something your students or colleagues might be surprised to learn about you? So something new.
So my day has 24 hours like theirs.
Okay, very good. One word that best describes your approach to science and to life. Just one word.
One word? No, I have a sentence. So research is what I'm doing when I don't know what I'm doing. And so that's a quote adapted from the famous German physicist Werner von Braun, who said that. So I think I like that. And it's guided my research all my life. Okay, let's say every patient could be an object or subject of research.
What keeps you hopeful about the future of cancer research?
Well, it's challenges. We have now new opportunities like CRISP treatment, which is definitely going to change the treatment of certain genetic abnormalities. And so the CRISP treatment, maybe also targeted agents in the future. So the challenges and the fact that novel insights lead to novel treatments. Sooner or later.
Yes, of course. And last but not least, we would like to know your suggestion. Whom should we interview next and why?
Well, as I mentioned earlier, so I have a great admiration for my colleague, Harry Groen, who is professor in Groningen. He also retired a couple of years ago, but he has a very, very, like me, a very broad field of interest in the field of thoracic oncology, so covering all aspects from screening to advanced disease, etc. And we are soulmates.
Thank you so much. Awesome. We will definitely take this into account and we will contact you for more details about your colleague to schedule the interview. Thank you so much, Dr. Meerbeeck, for your time and for joining me today. That concludes our conversation tonight. Thank you for being with me. That was such an interesting and lovely conversation with you.
Thank you.